Assalamu alaikum, students. So today we are continuing our discussion on blood pressure regulation, and we'll finish this off by discussing a few integrative CNS responses, and then we'll start and end the very important topic of hypertension. So these are the two learning objectives. We'll be looking at various integrative scenarios, and it's important because cardiovascular system is well, in its essence, it's a two-system unit. So heart and circulation, they combine to give you a lot of mechanisms that regulate uh, so many aspects of the human body. Blood pressure being one of the cornerstones of those mechanisms. And not just heart and circulation, there are so many other hormonal overarching mechanisms and CNS mechanisms that are integrated in this complex maneuvers rather. So we call it integrative scenarios. And I thought that it's important for you to look at this data which we have been looking at in bits and pieces here and there. You need to see it as a holistic picture. So this aspect of the lecture will should basically serve as a revision and as solidifying the concepts that you've acquired over the last couple of lectures, specifically since we've started looking at local blood flow, and then we moved on to arterial blood pressure regulation. And then the second is hypertension, its various types, its clinical importance, evaluation, and management. We'll touch upon that because due to sedentary lifestyles and the modern way of living, urban living specifically, hypertension has become a pandemic together with obesity. And these relations need to be understood right from the beginning of your undergraduate studies because you'll be dealing with this, unfortunately, most of your life in your patients. Okay, so integrative scenarios in which I've taken a couple. So this is basically where hemorrhage has caused decrease in arterial pressure, and it has triggered all sorts of blood pressure regulation mechanisms. So, of course, any decrease in blood pressure will trigger the whole timeline, which we discussed yesterday, of blood pressure regulatory mechanisms, starting from baroreceptor, going on to the renin-angiotensin vasoconstrictive response, and then eventually going on to renin-angiotensin aldosterone response. And in between, you'll have all sorts of fluid absorption at the capillary level going on in the intermediate uh, timeline zone. So this is where you have acute, this is intermediate, and this is intermediate and long term, depending on which part of the renin-angiotensin system you're talking about. Okay, so quick revision: we know that a decreasing blood pressure will trigger uh, uh, will will trigger the reflex in a way that it basically the stretch receptors will be unloaded, there'll be less stretch on them. This will eventually, through the vasomotor center, integration center, it will increase the sympathetic flow. We've discussed this in detail yesterday. And then we all know what sympathetics can do to the heart, to the circulation, to the veins, and that all is geared towards improving the blood pressure. We'll do the capillaries first. So in capillaries, this decreased hydrostatic pressure will lead to fluid absorption from the interstitium, and that is supposed to increase the blood volume. We also studied stress relaxation, and in this case, you will have some sort of a contraction at the level so that the blood pressure inside the vessels is improved. Moving on to renin-angiotensin vasoconstrictor event, this is supposed to increase TPR, and if you put in the aldosterone bit, it is supposed to lead to sodium reabsorption, which then would lead to increased blood volume. And all of this is geared towards improving the blood pressure. A word to note here is the ensuing half, latter half of the lecture is basically going into some nitty-gritties of hypertension. And one of the main causes of hypertension is kidney disease. So we'll be covering that today. And for that, I sent you a WhatsApp message. And for students who are not on my WhatsApp, a word of caution that I gave my students before they start listening to this lecture is to be absolutely very clear on renin angiotensin aldosterone axis. This mechanism needs to be very clear in your mind. So you need to be very, very clear here, and I'll just say it here out loud that renin angiotensin, or rather renin, gets secreted when you have a decreased GFR, and we've done this already, but I'm revising it for you. So, said in another way, if kidney is hypoperfused, if you decrease the perfusion of the kidney or kidneys, it will start to produce renin. Renin will then eventually lead to production of angiotensin II. Angiotensin II has two effects, two main effects. One is to increase the total peripheral resistance because it's a vasoconstrictor, and by this it increases the blood pressure directly. And mark my words here, this is the direct effect of angiotensin II on blood pressure. And then through aldosterone, which indirectly, which will then lead to sodium reabsorption, and that will lead to increase in blood volume, and that will then contribute to the overall blood pressure. So in hypertension, we will be studying what if there is an increase, abnormal increase in renin, which has then led to an abnormal increase in angiotensin II levels. What will happen? What will result? The result will be hypertension. Why? Because if angiotensin II over states its effects, that will lead to increase in the vasoconstriction that it naturally triggers. So if you really increase this aspect here, you will have systemic hypertension, okay, because of vasoconstriction of the arteries of the whole body. So that's one aspect, and this is the aspect which you will find quicker. So angiotensin II goes up in the blood, abnormally up. The immediate effect will be mass vasoconstriction and blood pressure rising. A more sustained and long-term rise in blood pressure, which will uh, keep on creating hypertension in the long run, mind you, is because of the raised aldosterone that this angiotensin II will keep on triggering because it is high in the blood. It is one of the stimuli of aldosterone secretion. So if this is increased, naturally this will be increased as well. But this is the bigger problem, I would say, that if you have a high aldosterone, the sodium reabsorption will be higher, abnormally higher in this individual. Uh, in other way, we are saying that this person is retaining salt and very importantly, the water that comes with it. So water and sodium both are being reabsorbed. They are kept in the body abnormally. They're not being excreted, leading to higher blood volume. And we have discussed this already, that volume leads to pressure. If there is more volume in the same fixed cardiovascular system, which is closed, and if you load it with more volume, naturally, what are you doing? You are increasing pressure. So this is the basically the crux of the hypertension lecture later on. So please be advised that you need to be absolutely clear on this concept. Right. Then there is another scenario of standing. I touched upon this, that baroreceptor reflex basically it helps you in your day-to-day mundane activities, even getting up from the sitting position. You go against gravity and all that scenario that I discussed in detail yesterday. This is just a revision of that. Standing leads to pooling of blood in the veins, which again drops the arterial pressure. Remember, this is the effect of gravity. Baroreceptor reflex is triggered. Again, the same sequence of event. Sympathetic outflow is increased. Heart, arteries, veins, all is should be very clear by now, and it leads to increase in blood pressure. Just that little tad that you want while standing up, the BP will drop, and it's all split second really. it will drop because of gravity, and immediately within a second or two, this whole thing runs because it's basically a very acute mechanism, and blood pressure in that instance, the drop in blood pressure is addressed. It's so transparent and in the background that nobody really notices this. You only notice it when you'll be dealing with this in the tutorial under orthostatic hypotension. So posture-related hypotension means that there's something wrong with the baroreceptor reflex, or your fluids are low because somebody had a bout of diarrhea, which mainly resulted in decreased body fluids. And when this person tries to get up, there is a possibility if the fluid loss is more, that this person may become dizzy and not be able to stand, or become wobbly. That these are all orthostatic hypotension, basically posture related disturbances in blood pressure. So the baroreceptor reflex is absolutely necessary for your mundane movement related tasks. Then this is something that we will touch upon later formally in another lecture. But I would like you to, I'll be referring this slide when I will discuss that formally under cardiovascular changes in exercise. But I wanted to show you this here as well, in addition, to integrate your knowledge about how the cardiovascular system behaves to ensure that there is more blood going to the skeletal muscle, but at the same time, you have uh, constancy or stability in the blood pressure itself. It's only very strenuous exercise in which we have increase in arterial blood pressure. Mild to moderate exercise does not significantly change blood pressure. That is something to remember. Also in this flow chart, you have the local responses in this same flow chart as the central command is there. So all this CNS business he has given very nicely. This is from Costanzo BRS. He has taken this local responses that we read under regional circulations. He has integrated this here. So to give you a bigger picture of how in during exercise blood flow to the skeletal muscle is improved, and at the same time, not shown here, but at the same time you have stability in blood pressure. It doesn't fluctuate much. Okay, so we've done those crucial overview scenarios that I was talking about. Now we start with hypertension. Hypertension basically is uh, is a sustained high blood pressure above normal. We will go into that in a bit. So what do we have here? We have an introduction. It is one of the most common health problems in adults on the globe. Okay, it is the leading. Let me just get this out of the way. It is the leading, as you can see here, the leading risk factor for development of cardiovascular diseases. The number one thing is hypertension. And mind you, this table I've picked up from a latest classification, which is being followed or should be followed by clinicians in detecting and treating and preventing hypertension globally. I will share with you the reference for that. And the rest of the actually most of the lecture is based on that document. So it's a leading risk factor for cardiovascular diseases. In the US, for example, approximately 25% of all adults above the age of 18 have high BP. That's a very significant amount of people. So 25 in 100 people in the US, um, according to last run latest statistics, they suffer from some sort of BP abnormality, and this is a serious concern. More interesting points about it is that younger men than younger women suffer more with hypertension. There is a racial component to hypertension. People with there's a socioeconomic component as well, and older people have more incidence of hypertension than younger people. Men have higher blood pressures than women until the women hit menopause, and after menopause, it's been observed that they develop hypertension more than premenopausal women. I just want you to visualize this small list, and it's a good investment for you as future doctors to see that cardiovascular factors, which are one of the number one uh, death causing mortality, death causing diseases in the world right now, cardiovascular diseases, the most prominent risk factor for these cardiovascular diseases is actually hypertension. Okay, so this is very, very important to note. That's why we are dedicating half of this lecture to your study of hypertension so that you are sensitive about this. And when you, inshallah, do end up practicing, you are very aware of your patient, most of whom, uh, let's hope not, but most of whom will practically be coming in with hypertension and you'll be dealing with that. The second is age. Obviously, no denying age. Age is a progressive phenomena. But as age goes on, you are more prone to cardiovascular risk factors. Diabetes mellitus, unfortunately, is one of the number one causes of cardiovascular risk factors itself. Then you have all sorts of lipid metabolism, which causes cardiovascular risk factors. Then you have kidney diseases, you have family histories there, obesity, and physical inactivity, which again, distressingly is seen in the youth of today. Sedentary lifestyle, even in the youth, leads to premature hypertension uh, casualty in young population. It's very, very bad. And then the absolutely horrendous and useless habit of tobacco smoking is one of the leading causes of cardiovascular risk disease. We will be looking at this part of this diagram. We'll be revisiting this table later on in this lecture, inshallah. Okay. So what are the types? So basically, there are two main types. You will find all sorts of explanations in Brighton and in other books and over the nets. Knowledge is not the issue here. The issue is how do you formulate it. So I've tried to make it simple for you so that you remember the main takeaway messages here. So one is primary. What do you mean by primary disorder? Any disorder, if you use the word primary with it, it means that it in itself is the problem, as opposed to secondary. I'll explain this business in a bit. I'll just need to define it. Secondary is secondary to something else which is causing the problem. So when we say that primary hypertension, what we mean is hypertension which is caused by a cardiovascular issue, probably caused in origin. However, when we say hypertension is secondary, we are saying that it did not originate in the circulation. So it originated somewhere else. So diabetics have hypertension. Now, diabetes is an endocrinological problem, okay, with the pancreas or obesity and so on and so forth. So it's more endocrine in nature, but it leads to hypertension. Yes. So this is what we mean by secondary. Another very famous trigger for hypertension formation, secondary hypertension, is kidney disease. So kidney disease is a whole set of issues with the kidney. Okay, then those issues with the kidney lead to, you can say it's a side effect. The side effect of kidney disease, a very famous one, big one, is hypertension. So that's typically discussed under secondary hypertension. Coming to primary hypertension is also called essential hypertension, and it accounts for the majority of cases that you'll be seeing eventually in your practice. And that's the kicker. It does not have any significant evidence other than probably obesity. You cannot pinpoint why this chap has high blood pressure. This is the off-throwing part of it. He or she will give the history, and the examination will reveal and the investigations will reveal that this person has elevated high blood pressure, and it fulfills your criteria, the diagnostic criteria, but you will not be able to pinpoint the cause of it. And this is the problem However, since these are the majority of cases, they have developed detailed protocols of how to deal with it. So that's good. Secondary hypertension, the whole role of your management and your diagnosis should be to go for the cause of this hypertension, and because unless you don't treat the cause, you won't treat the hypertension. That is not the case in primary hypertension. In primary hypertension, hypertension itself is the symptom and the disease. Since there is no evidence of any other disease, so you just treat the hypertension. Okay. This is the document that I was referring to, the seventh report of the GNC, the Joint National Committee. And what does that committee do? It basically looks at blood pressure. The various aspects of blood pressure is how to prevent it. If it's not prevented, if it's there, then how to detect it, evaluate it, sort it out, what type of blood pressure aberration is there, and then importantly, how to treat it. Okay, this is basically a US Department of Health and Human Services initiative. I've searched for a latest version, but could only find the seventh report on it, which is dated 2004. Maybe there's a new thing out. I've gone to the PubMed website as well, but I couldn't find. If anyone knows of a more recent endeavor on this issue, please comment in the section below the video, and so that we all are updated about it. But this is this is okay for our reference for a basic science lecture. So I'm gonna go ahead with that. So primary hypertension, according to this document, basically, don't be worried. There's a lot of data here, but it's it's a walk in the park. So in this table, it's very simple. He has compared, the authors have compared the latest document with the previous one. So there are some very important changes, as you'll see. Optimal means there's no problem. The person is actually quite healthy, even more than normal. Optimal means the way it was originally supposed to be. So systolic blood pressure over diastolic blood pressure. You know that 120/80 business, it's that. So if the person has less than 120/80, less blood pressure than that, the old category labeled this person as optimal, but the new category will label this person as normal. So clearly you see that there is a deterioration in standards. This is because hypertension is not stopping. It just moves on and carries on, and there are more people becoming sicker. So when they jotted down the sixth report, the situation was different. And when it time came for a revision to the seventh report, the situation had deteriorated. So optimal became normal, normal and borderline became pre-hypertension. Okay, so all the in-betweens between 120 and 139 in systolic and 89 in diastolic now is referred to as pre-hypertension. Remember, this is not a disease, but it's a warning sign that things are not optimal. They're not, certainly not normal now. We don't use the word normal for this. So anything which is above 120 and above 80 is something to be reckoned with. The cutoff line is 139 on systolic and 89 on diastolic. Okay, right. So okay. Then you have the hypertension statistic. There's consensus on this. Anything above 140 and anything above or equal to 90 sustained is hypertension. And then you have the substages of hypertension, stage 1, 2, and 3, which were then changed in this classification. Stage 1 remains the same, but stage 2 and 3 were merged into stage 2. So clearly, the incidence had gone up. Anything above 160 is basically now stage 2, and anything above 99 diastolic is now stage 2. It's important to look at it from a historical perspective as well, because that shows you the progression of disease and how people are dealing with it now. Experts are dealing with it now. Classification of based on this, the new classification of blood pressure for adults is this basically. The normal is systolic less than 120, diastolic less than 80, Pre-hypertension, as I mentioned, is 120 to 139, 139 being the cutoff. And in diastolic, it's 89 is the cutoff. Okay. Stage 1, hypertension, these are the figures. And then stage 2 is anything more than 160 systolic and more than 100 diastolic. This is the way that hypertension should be diagnosed based on these values. Recommendation, checkup recommendation. I found this to be of interest for you. A normal person who has normal blood pressure should be rechecked anyway. We are talking about adults here. Uh, in within 2 years. Okay, and remember, these are adults without any end organ damage. I'll be speaking about end organ damage in a bit. So people who right now don't have end organ damage with their blood pressure measurements. So normal needs to be checked every 2 years. Pre-hypertension rechecked in every 1 year. Stage 1 hypertension confirmed within 2 months. Whether this chap has modified his lifestyle or not, we'll talk about this. Stage 2 hypertension, basically a more aggressive way to not just pursue his hypertension, but also look for the sequelae of hypertension, i.e., which organ or organs are being damaged by this hypertension and how to limit this. Okay. So the contributing factors, basically we divide them into two: risk factors and lifestyle factors. Risk factors are things which are pretty much fixed. You can't do much about it. Family history, nothing can be done about that. Race, diabetes, if it's there, then diabetes is the main cause, and you can limit the effects of the cardiovascular effects that diabetes has. You can't really reverse them once they come into play, and they're pretty much in the progressive forwards direction. Age again is something which happens to everyone, and age-related blood pressure changes also happen to everyone. The extent may be different in people, but they certainly do happen. So, for example, arteries do harden because of deposition of fat in the walls and decrease in the elastic tissue. The nature of elastic tissue itself denatures along with age. So there's no stopping that. You can only retard it, but this just forwards. Age is not a disease, but it's a reality. These are the fixed risk factors. However, lifestyle factors, they can, thankfully, they can be changed, looked at and changed. If the salt intake is more, decrease the salt, and we'll be talking about salt in a bit. It's an interesting discussion. Decrease calorie intake, control obesity, increase physical activity. Hopefully, alcohol consumption is not an issue in this country. And in women, oral contraceptives has a very clear link with developing hypertension in females. So, lifestyle changes, modifications are the first things in a physician's mind to address, not the pill that is prescribed and the patient then becomes a pill popper. First, you need to discuss and convince the person to change his eating habits, his or her obesity, level of exercise, and so on. And many patients do respond to these lifestyle modifications, and they don't need any pharmacological treatment. Something which physicians these days are a bit trigger happy, I would say, and they go for the medication as a first port of call, which shouldn't be the case in our new generation, hopefully. Okay. Uh, so the manifestations or symptoms of essential hypertension, well, most of them are asymptomatic. Uh, they will feel the complications of hypertension, and maybe that is the point where they come and see you. Essential hypertension, since it's a response of circulation itself causing the high blood pressure, it does remain asymptomatic in most cases. However, sustained high blood pressure eventually accelerates atherosclerosis, and actually this is the main disease causing component in hypertensives. because this causes all sorts of cardiovascular disorders. And as I mentioned, we will revisit this table, and now we will look at this part of the table. Okay, so they are saying, and remember, if you have the time to look at the previous report, you will have a different organization of these diseases. This is very important, and hence it's important to see the historical perspective here, in the sense that some of these diseases were on top in the last report, but in the latest one, according to what I have found, this is the latest document, the heart as an organ is the number one recipient of atherosclerotic insult in hypertensive. So in hypertensive patient, eventually, as of latest data, heart affects gets affected most. You have left ventricular hypertrophy being the number one feature of heart damage in hypertensives. Then you have angina, which is pain of ischemia, myocardial ischemia. You have revascularization. You have heart failure. So advanced patients of hypertension go into heart failure when they present to the doctor. Then the second recipient of the injury is brain. You have strokes, you have dementia. Then look at this, CKD, chronic kidney disease. Very discussed matter in hypertension is the effect that hypertension has on kidney. Now, remember, don't be confused here. These things are bidirectional. Okay, kidney disease causes hypertension, and hypertension causes kidney disease. Okay, so let's be very clear. There are a set of kidney diseases which cause hypertension. This is not that list. That list will come up later on under secondary hypertension. This list is basically hypertension causing kidney disease. Okay, so sustained high blood pressure damages the vessels of kidney. This is what being is what being said. Peripheral artery disease is again that thing which constant increase sustained high blood pressure within vessels triggers a response from the atherosclerosis, in the sense that there is more deposition of fat in the wall, and also sustained blood pressure challenges the elasticity of arteries, of vessels in the long term, leading to quicker decrease in their elastic profile, beating age to it. uh, Retinopathy. So again, atherosclerosis of the retinal vessels will lead to ischemia of the retina and changes in the vision of the person. So hypertension, through its atherosclerotic weapon, causes all sorts of organ damage, and this is the way to look at essential hypertension. So it's a silent morbidity and mortality maker. Uh, Silent because it's mostly asymptomatic itself. It expresses itself via this weapon on the various crucial organs of the body. Diagnosis, again, it's not just one high reading of blood pressure that would prompt you to label this person as a hypertensive. There are protocols, and they should really be followed to the spirit. Let's not be trigger happy in labeling people with diabetes or hypertension based on single readings. That's most unfortunate. Repeated serial blood pressure measurements are the way to go. Diabetes is based, I beg your pardon. Hypertension is based on an average of at least two or more high blood pressure readings taken at each of two or more visits. So you ask the person to come back. If he or she has come to you once and you had two or more high blood pressure readings in that visit, ask the person to repeat the visit, or go home and make a diary of serial blood pressures, and then you study that diary and then repeat the blood pressure readings in your office as well. If all of this leads to a sustained image of high blood pressure, then you should be prone to make a diagnosis of hypertension. And then you have all sorts of lab tests, x-rays, etc., to exclude any secondary cause. So if this person, we're obviously discussing essential hypertension, it doesn't have a cause, or probable cause. How do you arrive at that? When you exclude all the secondary causes, then you label this person as a essential hypertensive patient. A leaf from Guyton is very interesting. I've taken this graph as well. So I'll be brief here. You can read this up a little more detailed from your book. Uh, Basically, one of the views, and a very strong view on hypertension, is that people generally uh, are can be divided into two types based on their salt response. So some people seem to be responsive, to be very sensitive to salt, while the others are not much. So the first category, the one who are salt sensitive, they basically they respond to salt much more acutely. So if they take a known amount of salt in their diet and they don't bother with decreasing it, they are prone to become hypertensive much more quicker than the salt insensitive people. We are not saying that salt insensitive people are somehow immune to the bad effects of high salt intake. We are not saying that. We are saying that all of us are sensitive to salt, because salt will increase the ECF volume and lead to higher blood pressure over a long period of time, or a broad period of time. But what we are saying is there are people who are more prone to these changes in response to their salt intake, and then there are people who are less prone to the salt that they take. And this graph is a clear testimony to that thing. The black curve is a normal response to high intake of salt. So he's taken normal intake at point D and then increase the salt in this normal person. It just he just threw this out, the extra salt. As you can see, that salt intake and output statistic, that it's just the curve did not shift anywhere. It just moved nicely vertically along. And when here the person was at normal intake, his blood pressure was around 100. And when you increase the diet intake, maybe slightly a few degrees to the right, but negligible really. And where did that extra salt and water go? The kidneys threw it out, because this is a normal person we are talking about. Now we are talking about essential hypertension tension scenario. The two responders. So the red one is the salt insensitive person. So this curve, it got displaced and became the red curve. So this person's response to normal intake, because this person is a hypertensive, is his hypertension is his hypertension anyway. And now this person is basically on a normal intake of salt. Now you've increased that normal intake of salt. So the blood pressure would sort of remain in the same category, although if you really look at it threadbare, there's a slight rightward shift, minuscule really. So this person is really salt insensitive. As you can see, that salt did not do much to his blood pressure. However, look at the blue line, the salt sensitive person. So these are the people who are very sensitive to their salt intake. And if it was normal, it was less than 150. But as soon as you gave him that same high intake of salt that you gave your normal person, and the salt non-responder, this person's BP shot up and went above 150. So clearly, there's a difference between essential hypertensives as salt insensitive people and salt sensitive people. An interesting discussion to take up from Guyton. Again, this is an important aspect when you're diagnosing your patient. Okay, so treatment. Treatment, basically, the main objective is to keep the blood pressure obviously less. But what is the cutoff line here? The cutoff line is less than 140 and less than 90. Less than 140 systolic, less than 90 diastolic. Basically, if you remember the definitions and the statistics we used early on in the diagnosis of hypertension, this is the cutoff line for hypertension, and you want to keep it lower than these values, and that's the mainstay of treatment. Now, What is the second most important part of the treatment is to prevent morbidity and mortality. The difference is morbidity is a disease causation and the suffering that comes with it, while mortality is death. So obviously, one of the mainstays is to decrease both morbidity and mortality. Okay, and how to do it? There is a lifestyle modification management protocol, which is being shown here again from the same document. Number one is weight reduction, uh, and there are details of this. You can study this. What is interesting is they have given a statistic of how much weight reduction how much decrease in your systolic blood pressure can you achieve per unit body weight by this measure only. This is a very interesting statistic, especially for people who are above their normal weight, their normal BMI, and they suffer from some sort of hypertension. Weight reduction in itself, look at the stat. This is motivation enough to go for hitting that treadmill or going to the park. Diet rich in fruits, vegetables, low in fat, low in dairy, and look at the dividend that you get for that. Okay, then sodium intake. As people move along the age clock, salt needs to come down. They have shown, Guyton discusses this in some significant detail. Do read it once. It's gives you a picture of how salt is such a big issue as you move along the age continuum. That you need to really decrease the salt, and you must have observed that elders in your house they are very picky or finicky about salt, and there's a reason to that because in old age salt can create more volume related issues and directly more blood pressure related issue than when you are youthful. The kidneys are older, they are frail, their handling of the salt may not be spiffy as a younger person. And so it's better to eat less than to load your ECF volume and then do the kidney not a big favor. Just eat less salt, okay? And look at the dividend that you get on systolic blood pressure reduction. Physical activity cannot be argued more, is essential for blood pressure reduction. And hopefully, this may not be a big issue, but in the West, it is a big issue to decrease the alcohol consumption. And this also has a significant role in systolic blood pressure reduction. Right. Pharmacological treatment, basically a range of drugs are there to help. And as you go down this list, basically you are dealing with uh, new diabetics. You can treat them with diuretics. Diuretics basically are drugs which increase the volume output of the kidney. So you're getting rid of extra volume, bringing the pressure down. These are diuretics. And as you go down this ladder, the hypertension person is becoming more complex. So you're talking stage one and stage two here as you go down. Also, there are protocols where you combine two different class of drugs. So there are single drug treatments of hypertension, simple hypertensives. Then there are two drug treatments protocols defined for resistant hypertension, which is more difficult to treat. So they have to use two drugs and try to manage it. And remember, pharmacological treatment cannot be, I'm saying this again, cannot be the first thing that you do with the patient. The first thing that you have to do is counsel about lifestyle modification and put this chap on lifestyle modification. Make notes for him. Do hard work as a physician. It's hard work getting people to change their habits. So all this business, this needs to be talk to the guy, try to convince the person that these are the modifications which will significantly reduce the blood pressure on its own, and then ask him to come back for a follow appointment. And then and this is that running theme of hypertension that I was posting on Facebook, is put him on a medication, be conservative in using of medication, especially when you can prevent this. So if he or she only shows resistant, his hypertension is resistant itself to your lifestyle modification chart, which you made meticulously for this guy, only then go for the pharmacological treatment. So we've done the primary hypertension, the essential hypertension. Coming to secondary hypertension. Okay, so as we mentioned earlier, that primary hypertension, essential hypertension does not have a obvious cause. Secondary hypertension does. Okay, and in this, one of the main uh, causes relate to kidney. Kidney itself can cause hypertension, and we'll look into this. We'll go into details. Uh, a word of advice here is that I'll be, because of the scope of the lecture and the time duration, has put some restrictions on me. This cannot be a horrendously long lecture. In secondary hypertension, the books have given lots of other causes of secondary hypertension. So you can imagine, and I will show you the causation table as well. Uh, there are a lot of organs which, if they become faulty, they can cause hypertension. But I've picked renal because Guyton has picked renal and has invested most of the comments, the main comments on kidney causing hypertension. So I will focus on this. However, word of caution is you have to at least give one reading to the other causes as well. Okay, so those other organs that Guyton and other books talk about, which may cause hypertension under the secondary hypertension heading, you have to at least give it one reading. All right. However, my lecture from this point onwards will focus on mainly the kidney causes. So the largest single cause of secondary hypertension is renal, renal cause. And all these sorts of problems with the kidney, the famous diseases, glomerulonephritis, acute renal failure, renal obstruction by a stone, polycystic kidney disease, diabetes comes in again. So diabetes also causes kidney disease, which then causes hypertension. You can see the enormous mess a person can be being a diabetic. And type 1 is, again, you're born with it. But type 2, pretty much you put it upon yourself. Again, it has genetic component. But if you can just manage your diet and not be obese and just easy on the junk food and this sort of thing and do more exercise, diabetes type 2 can be managed. But once it sets itself up in a person, then kidney goes, then cardiovascular goes because it triggers hypertension. End stage renal disease is all obviously the last station in this sad saga of kidney disease, after which hypertension becomes a raging problem in this person. So kidney is one issue that one has to deal with, and now you have to deal with hypertension as well. Okay. Um, there was a graph. Okay, fine. So this is basically, let me just show you again. These are the causes of kidney diseases. These are kidney diseases causing hypertension. Okay. Now, each one of them has a story of its own. Okay. You may look at it in your own time. All right. However, the mainstay of Guyton and other standard textbooks is this: renovascular hypertension. What is this? So while we can talk about an acute renal failure, shutdown of the kidney, and how does that cause uh, fluid retention, which then goes on to cause hypertension, uh, this particular aspect, this slide basically is about renovascular hypertension. So so we are talking about the original issue. The original issue is something is wrong with the vasculature of the kidney, not its parenchyma, not originally. You're talking about the first shot that was fired, the initial insult. Okay. Uh, so the initial event was wrong, something became wrong in the vasculature of the kidney. Okay, so be very clear. Renovascular is a big topic in hypertension, secondary hypertension. One of the main causes of hypertension, kidney-induced hypertension, are due to renovascular causes. So this is where that renin-angiotensin-II axis will come into play. Okay, that's why I asked people to revise this thoroughly so that we can negotiate this slide. Okay, so now let's slowly descend into the thick of it. We have three scenarios, three main scenarios. Okay, uh, one is a renin secreting tumor. Okay, so what will happen? Renin is, you know where renin is secreted from, the JG cells, right? It's part of the mainly the afferent arteriole, also part of some of the efferent, but mainly the afferent arteriole. Okay, so it's again a vascular issue. Now it has developed a tumor. What will happen? What will happen is this tumor will abnormally increase production of renin. Renin will then lead to a equal amount of abnormal levels of angiotensin-II. And you now should remember what angiotensin-II does. It increases TPR. So direct action is a rising of the arterial blood pressure enormously. And then you have a delayed component via the aldosterone fluid retention wing of it. And this causes that sustained chronic hypertension. Okay, so this chap will come up with a sustained high blood pressure over months to years, uh, maybe months rather, because the blood pressure will be raging and this chap will need to be treated quickly. And after an imaging study, you will find that there's a tumor. The blood levels of renin will be abnormal. You will go for imaging. That will be the tumor. You will need to treat that tumor, and the whole thing will come back to normal. So this is one of the examples where it's this axis which causes the hypertension, and this axis relates to the renovascular aspect of the kidney. Number two is renal ischemia. This is where the physiology, pure physiology kicks in. Okay. So Guyton discusses under renal ischemia further two aspects. Let me go slowly here. By renal ischemia, we mean that you have decreased blood flow to the kidney to the extent that the normal filtration processes of the kidney, which the kidney is supposed to do, have decreased. GFR drops. So, if you decrease blood flow, ischemia causing decreased blood flow of the kidney, what are you doing? You're not supplying the kidney with enough blood for it to do its job, which is filtration, and then giving you back the renal. Remember the renal blood flow that we talked about, that 20% becomes the filtration fraction and 80% is given back to the circulation, right? And even in that 20% filtration fraction, most of the stuff is reabsorbed and given back to the circulation. You remember all that discussion, I hope. So all of that is reduced when you decrease the blood supply of the kidney. Okay. So what are you doing? You are basically retaining unfiltered blood in your circulation. That's one thing. Number two, what you are doing is you are asking the kidney to secrete renin. Okay. I need not go into detail why this renal ischemia will cause renin secretion. You should now be able to pick this up. Okay. So renal ischemia will cause renin secretion, which will then cause angiotensin-II formation, which will then add to the woes of this patient. It will add on an already extra volume retained circulation. It will cause vasoconstriction. Okay. And through its aldosterone wing, it will cause even more fluid retention, even more retention of sodium and its attendant volume, water. So all of this picture should paint for you that renal ischemia will cause or exacerbate hypertension. Okay, I hope that is clear by my description. Now, if that is clear, if it's not clear, please pause this video, and what I've said up till now, just try to reconcile it with your knowledge of renin, angiotensin-II, aldosterone, reflex, the whole flow chart. Just read it again, and up till this point, you should be clear about the statement that renal ischemia via this whole thing causes hypertension. Okay, if you're clear on that, now we are good to go. Now we can talk about the two Goldblatt hypertension scenarios that Guyton talks about. Goldblatt was the physician who studied this hypertension, so that's why his name is there. There's the one kidney gallbladder hypertension, and then there's a two kidney gallbladder hypertension. Simply put, this scenario is mostly in transplanted kidneys, or scenarios where the person has somehow lost one of his kidneys and is just working on one kidney. So single kidney. The person has a single kidney. Remember that. And in that single kidney, through various scenarios, it can be anything really, but it has to be vascular. Uh, in this single kidney, you have somehow managed to decrease the flow of blood into the kidney. It can be renal artery stenosis. It can be any scenario where the resistance of the renal arterioles due to an atherosclerosis plaque or excessive vasoconstrictors, somehow the resistance has increased. So the nutshell is this kidney is not receiving its allotted blood flow, which in the single kidney means a lot of blood flow because the single kidney has to compensate for the absent kidney as well. So in this scenario, you have decreased the blood flow to this kidney, causing renal ischemia, causing more renin, more angiotensin, more hypertension. So one kidney gallbladder hypertension is basically due to renal ischemia in a single kidney in this patient, and its attendant hypertension. Okay, that's this. Then you have the two kidney gallbladder hypertension. Very simply, this person can be this person has two kidneys, but the stenosis, the atherosclerosis, whatever blockade is there, it's only in one kidney. Okay, so now imagine there are two kidneys. One kidney has the renal ischemia, the other is normal. Now the renal ischemic kidney will be forced to produce more renin, more angiotensin, all that business. But once the renin hits the blood, it goes everywhere, right? It will go into the kidney, the normal kidney. It will go to the lungs and all that sort of thing. And when angiotensin gets formed, angiotensin-II gets formed, it will not differentiate which kidney are you. So it will affect the vasoconstriction of the efferents in the diseased, in the ischemic kidney and the normal kidney. Okay, because angiotensin-II does not know which is which. It is a vasoconstrictor. It will just constrict all the vessels. So normal kidney gets affected as well. Aldosterone, when it gets formed, it will not make a distinction between which distal convoluted tubule do I have to work on. It will work on every DCT in both kidneys, the ischemic and the normal. So the normal kidney also has to behave in the same way as the ischemic kidney, but the cause is different. The ischemic kidney is producing the increased renin, which is causing all of this havoc, while the normal kidney is just responding to the high angiotensin-II levels. Okay, so causes are different, but they end up causing fluid retention. Both of these kidneys end up causing fluid retention. So the result is the same, however, the cause is different. Okay. This is called two kidney gallbladder hypertension. This can be a viva question from good students. Maybe the person will be asked to define hypertension, and depending on your confidence and your previous record, they can directly come to the difficult stuff. I have intentionally skipped a a graphical representation which Guyton gives along this topic. It's a very good graph. I was tempted to use the graph, but then I was also sensitive about the amount of information that this lecture packs. And the clinical information is also a lot for a first year to handle. That's why I've skipped that graph. But the brave ones amongst you, and I know there are some, they should go for that graph. It is given in the section where he talks about hypertension, with angiotensin being the cause of it. Okay, it's near the latter third, last third of the second chapter, dealing with long-term regulation control of blood pressure. Let's hope you find that graph. Okay, and if you have questions or if you want to comment on that graph specifically, you can again use the comment section of this video. Lastly, this chronic renin secretion, it is not the same as the tumor. Okay, this is actually quite different. So this tumor is actually a tumor of the renin secreting cells. However, this scenario is interesting in the sense that imagine a kidney which has part ischemic tissue, patchy, some patchy areas of ischemia, while the rest of the tissue is normal. So within one kidney, you have patchy areas of ischemia with interdispersed normal tissue. So within the same kidney, you can have this effect. How? Is the ischemic parts of this kidney, or both kidneys, is the ischemic parts, the bad parts, will cause renin secretion, will cause angiotensin-II production. So it's the technology is the same, okay? And the only difference is that those patchy areas, by instigating this formation, uh, angiotensin-II will then affect the normal parts of the kidney. Okay, we're not talking about whole kidneys now. We're talking about within the kidneys, the ischemic sections producing renin and angiotensin-II, which then eventually affects the normal part to behave exactly in the two kidney gallbladder scenario. So both the outcome is the same, fluid retention, but it's literally the two gallbladder scenario within the same kidney. Okay, I hope that's clear. So these are the the three scenarios of the kidney-induced hypertension aspect, secondary hypertension. And with another reminder to please go through the rest of the causes of the secondary hypertension at least once. But really, if you cannot afford to skip this. This is the mainstay, because kidney is the number one cause of secondary hypertension. So you really cannot afford to skip this whole thing. However, reading those other causes is also important. Okay. Finally, the references, and this is that document that I have mentioned thoroughly in this presentation. So this basically brings us to the end of arterial blood pressure control, both acute and chronic. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuhu.